Top Med Talk.
Hi, it's Desiree Chappell here in the Top Med Talk team. I hope you're staying safe during these times. We wanted to say thank you for downloading Top Med Talk. This piece is not specific to the COVID-19 crisis, but we are covering it daily. If you want more of that information, you can find it on topmedtalk.com. Now, in the meantime, we are continuing to champion perioperative medicine like we always have done. And we're working with our academic partners as the crisis continues to bring you our normal scheduled content. We also want to say thank you to our sponsors, specifically Edwards Life Sciences, for their generous support. I hope you enjoy this podcast.
It's a great pleasure to introduce my friend and colleague, Chris Snowden. He is a consultant anaesthetist at Freeman, Newcastle upon Tyne, and a senior lecturer at Newcastle University. His clinical job is a major surgery. He's extensive experience in developing preoperative assessment pathways and is a clinical lead. He incorporates cardiopulmonary exercise testing. He remains research active and has a research grant from the National Institute of Academic Anaesthetists, the Royal College of Anaesthetists and the British Journal of Anaesthesia to develop prehabilitation training elderly surgical patients. Chris's overall work programme aims to promote the transformation of anaesthetists into a broader base of perioperative clinicians. He also works part-time for NHS Improvement and NHS England, doing a fantastic and very important job of getting it right first time, where he's investigating clinical variants from all perioperative medicine services across the UK Trust. Thank you.
Thanks very much, Sandy. So the first time I spoke, it's great to see everybody here and sort of embracing prehabilitation. The first time I spoke at this conference was in Canada, and I was asked then to speak about activity. Now I'm asked to speak about alcohol. It doesn't say much about my lifestyle choices, I'm afraid, but I have disclosures that I do have a grant at the moment with the NIAA. I'll go through the study that's been supporting. And I have no conflicts apart from I do drink alcohol. And actually, most of us, I think, as doctors, probably do. We've had some really poor messaging from doctors about alcohol and how much use alcohol is. And I'm sure I'm not the only one in the audience who remembers writing up Guinness on a drug cardex or whiskey at the end of the night. Yes, there's a few of you, I'm sure. So we don't give out some very consistent messages as doctors, but other people don't give out consistent messages either. So this is the alcohol industry supposedly promoting moderation, but also promoting this fantastic all-day IPA session IPA. There is so much wrong about that slide that he is actually lawn mowing while he's absolutely off his head. So the messages are completely and utterly different. And unfortunately, the tabloids and the press get it wrong as well. That's great. This middle-aged lady, she's as long as she can have 2 days off the alcohol, she can have 3 days getting completely sloshed again. So the whole thing, the messaging about alcohol is wrong. One message that is coming out from the public health sector is that alcohol is bad for us in terms of the whole public health. And this is just a graphic from the public health sector looking at the impact of alcohol on the NHS particularly, but on general chronic illnesses and cancer as well. So completely different messages. But what are the real facts about alcohol? This comes from NHS Digital. It's England 2018 data. And what we've seen with all this messaging is there has been a subtle change in what we see with regards to alcohol intake in our population. So the binge drinking that we used to see around the young, that over the years has gone down. Now, the 65s and over never really binge drank at all. But the young population have changed their drinking habits. They're not drinking half as much as they used to. So those pictures of young people on the streets are not as common as you would imagine now. And actually, the highest risk drinkers now are in that age group. So 55 to 74, that's where you see all your surgical patients. And these are the hospital admissions that are coming in for alcohol-related injuries. And again, 55 to 74, they're not the young people at all. And they're not just coming in for alcohol-related problems per se, wholly attributable. They're coming in with this systemic insult related to alcohol. So this particular one is cardiovascular disease. So all your patients who are coming in, surgical patients about that age group that you would expect, with disease related to alcohol that's going to affect your anaesthetics and your surgery. So it is a teachable moment. It shouldn't be a moment forgotten. This is something that we need to stamp on very carefully. So what is the data out there about stopping or doing something about alcohol? This is a very early study in 1999 from Tonneson, but also Heinrich Kellick, actually, the enhanced recovery godfather. They looked at 42 patients having 5 to 6 bottles of wine a week, so very, very high input. And they used some intensive treatment, disulfiram, which is a drug that makes you, when you drink alcohol, it makes you much worse. They had some uncontrolled behaviour in the control groups, but their study was put into this Cochrane review, which then occurred in 2013. And this is the only Cochrane review to be done on alcohol in post-operative complications, etc. So you have the whole total of data is 69 patients. Also, interestingly, the same people who did the 1999 study as the 2002 study, they're exactly the same. And the interesting thing is also the authors of this was Tonneson as well, who's involved in it. So a Cochrane review says not very much about the effect of stopping alcohol in those high-risk patients. But it does say that it does give you that signal, even though it's a very small number, for a reduction in complications. As we move on, the data becomes a little bit more clearer. We see that most of the alcohol-related problems post-operatively are infection. So if you look at infection-related complications, that changes. And as we move on, there is an awful lot more studies that have started to occur. And looking at a meta-analysis, the odds ratio is actually, if you take alcohol in lots of different ways, then the odds ratio, you will be more consistently open to complications after operation. The interesting thing is, from this slide, obviously, is this is an increasing dose up here, and you can see that there is a pretty consistent component. As you increase your dose of alcohol preoperatively, you have more complications. And that's a really consistent theme that comes through some of the more relevant studies recently. So this one, 2011, you can see at low risk drinking, this is the audit score, which we'll talk a bit about later on, alcohol intake. As you move up those dosage range, your risk of complication starts to go up. But it bellies out at low risk. And actually, if you abstain, some of those complications go up. So that's good, isn't it? Excellent. And it's even more important because this is a very big study that's just been put through in 2017, 90-day and 1-year risks of mortality among 30,000 arthroplasty patients. Big meta-analysis showing that 90-day and 1-year mortality after this big group of orthopedic patients, if the abstain is taken as standard, if you drink a small amount, that's sort of 2 bottles of wine a week versus 2.5 to 4 bottles versus 4, you can see that actually the hazard ratio is less for low drinkers, and it moves up as you go through the high drinkers. So perhaps the message we should tell to our patients is not to stop drinking, but actually to reduce down to your low risk levels. And that's an important behavioural change message that we should perhaps come out of alcohol. So what's happened? Well, how can we develop that? Well, there's this new sequence that's just come out from the NHS. It's incentivisation in terms of identifying, recording alcohol intake and giving brief advice. And this is a nice paper from the BMJ in 2015 looking at how the generalists and the specialists can change the way we look at alcohol and how we give it. So generalists and the specialists. Really, as generalists and perioperative physicians, we should be looking at awareness, screening and brief intervention and perhaps diverting the higher risk drinkers off to other specialists. Just take this is increasing risk. This is the hazardous drinking group, and just look at that percentage because it becomes relevant later on, 16%. So are there tools out there that we can use? Yes, there are. This is the audit screening tool to screen our patients for alcohol intake. And really all it does is ask 3 questions, which you probably ask in your general history taking anyway. How often do you have alcohol? Do or do you not? How many units do you drink on a typical day? And how often you had a binge, basically. Those are 3 questions. If you ask that and structure it in a way that you can use this audit score, that's your screening tool. And that's the one that the public health are wanting us to use within the hospital environment. After that, we have to have an intervention, and this is brief advice. So there's over 30 years of research on brief advice interventions in alcohol. There's 24 systemic reviews. It's best for risky drinkers, not dependent drinkers. So that's where the early data, I think, was flawed. It's consistently effective, and the brief input is enough. You don't have to go for extended input in these type of drinkers. So those are the brief interventions that work not in the perioperative sector. We've got to put it into the perioperative context. And we were lucky enough to get a grant from the NIAA in 2014, started in 2016, to look at whether we could use this screening and intervention process in a perioperative context, out of a perioperative clinic, to actually start developing these processes of behavioural change and moving patients from a high-risk drinking to a lower risk. Now, it's a feasibility in a pilot, so it hasn't got any outcome data, but that's what the NIHR wanted, because this is such early days. We haven't done this sort of thing before. It was led by nurses in our clinic, and they used the screening behavioural change tools that you've just seen. And what we learned from it, and this is very early days, as I say, what are we learning from it is within the context of a study, screening and approaching the patients is not a problem. They're expecting you to ask questions about alcohol intake when they come in for their surgery. Screening has to be done face-to-face almost. It's very difficult, or you get less patients interested in screening themselves if you do a postal screening process. So we don't get from the feasibility to the pilot study, we lose patients. But what is interesting is those eligible, so the patients you see, the percentage of patients you see is exactly the same as the general population. 16 to 18% of those screened will be risky drinkers. So we have the same population as we expected in that BMJ article. The ones who express interest at going into the study, and again, this is in a context of a study, patients don't like doing extra things. They don't like study demands where they have to come in for an extra visit. So I think this expression of interest rocks down between feasibility and pilot study because of that. But what is important is if you get your correct message right about reducing alcohol and not just stopping dead, then a lot of more of patients want to consent to the study. As I say, it's got the problems of an RCT, but it's more important that the message is given out, that it's reduction, not cessation. So what have we concluded from that? that these alcohol intervention processes, the screening and the brief intervention, is feasible. It's doable within the perioperative clinic, and that can be nurse-led. The processes are acceptable and they're readily available. If you give the right message and avoid pejoratives like risky, you make sure that they understand what a unit and a drink is, and then you can convert them. And it's very much more about the intervention is a motivational change rather than a volitional change at this point in time. If you want to change things from a higher risk, even higher risk alcohol intake, it has to be a bit more extensive advice. The study recruitment was moderate, as you saw, but what was really important and interesting is the retention of your patients was very high. So we retained, so if they went and consented onto the study, 96% of them were retained at 6 months follow-up. And there are very good signals that they're still reducing their alcohol intake at that point in time. So we do need a larger trial, and we've gone back to the NIHR about that, and hopefully they may commission it, and we'll be wanting centres around, certainly around the UK, because it's NIHR, to actually come on board with that. So as a summary, we all give lots of mixed messages because we're probably conflicted about our alcohol intake and our patients. The changing alcoholic demographic is very interesting, but it makes it so much more relevant to your perioperative surgical patients. And there is an effective association with preoperative alcohol, but the cause and effect is a very difficult, complex case, and it relies on dose dependency, it relies on age, it also relies on behavioural clustering, smoking, and other behaviours as well. But what we should be doing as perioperative physicians is embracing that moment. It is obvious that we need to. We have to provide a consistent message, and that's probably at the moment with the evidence reduction, not complete cessation. We use the tools that are available and have worked in other environments, and we've started to show that they can be used in the perioperative sector to understand our behavioural change implications and use our behavioural change colleagues and make sure that this is all integrated into our programme of education of doctors, healthcare professionals, etc. And one thing, just to finish off, the surgeons are already doing it, unfortunately. They've put it in their core competencies in 2012, and as far as I know, we haven't. So we as anaesthetists need to start doing it, not just anaesthetists, all the people involved with prehab and perioperative medicine. Thanks very much.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.